Hello, everyone. Welcome. Thank you so much for joining us today. I wanted to welcome all our virtual participants and, of course, our speakers today. Today, we will be discussing three very important conferences that happened within the last 6 months, reviewing the International Gastric Cancer Congress, the European Society of Medical Oncology, as well as the American Society of Clinical Oncology Conference. So that's IGCC, ESMO, and ASCO. And for those of you that don't know, these are essentially the Holy Bible conferences where a lot of the research and science about gastric cancer, stomach cancer, and gastroesophageal cancer is shared amongst doctors, scientists, as well as the general public and patient advocacy group. So if you've not been to one of these conferences, they're quite overwhelming. But if you want to learn about gastric cancer, this is it. My name is Katy. I am the vice chair and co-founder of My Gut Feeling. And of course, you all know Teresa Tiano, who is the chair and also co-founder of My Gut Feeling, and she'll be speaking today. I would like to introduce our speakers today. So the first speaker is Howard Lim. And Howard Lim is medical oncology at BC Cancer Center in Vancouver. He specializes in gastrointestinal cancers, as well as being the clinical associate professor at the Faculty of Medicine there. Also, Natalie Coburn. She is a surgical oncologist at Sunnybrook Hospital Odette Cancer Center here in Toronto, who practices specifically with upper GI cancers as well as hepatopancreaticobiliary cancers. And she does a lot of research in this sphere as well. And then, of course, Dr. Sharlene Gill, who is the professor of medicine at the University of British Columbia and a medical oncologist also specializing in GI malignancies at BC Cancer Vancouver. And then Teresa will introduce herself, although she does not need any introduction. But we have three very highly regarded medical experts, and we hope today to engage you in some interesting topics that we learned about through these conferences, as well as facilitate a discussion, get to all your questions or as many questions as we can today. And remember, this is an open space. This is your opportunity to ask anything and everything from these highly regarded experts. For those of you that don't know about My Gut Feeling, so we are the first and only nonprofit specializing in helping patients with stomach as well as gastroesophageal cancers. And for those of you that don't know what we do, so we have 4 pillars. The first pillar, of course, is support. So we support patients, survivors, and caregivers. And we have 2 monthly support groups that are run virtually all across Canada. One is for patients and survivors, and one is for caregivers and those who have lost a loved one to stomach cancer. Our second pillar is education, and as hopefully you guys are aware, our major conference, our annual stomach cancer conference is coming up in November, Saturday, November 15th, and we will release more information shortly after this webinar. Of course, we also advocate for stomach cancer research as well as novel therapies for stomach cancer patients. And we do that both on the government as well as the drug reimbursement side of things. And of course, we raise awareness about stomach cancer. So November 30th is Stomach Cancer Awareness Day. And if you know anything about stomach cancer, the color of stomach cancer is periwinkle, and we light the world up in periwinkle. So without further ado, I would like to introduce our first speaker, and that's Dr. Howie Lim.
Great. Thanks so much, Katy, for the introduction, and thank you to all of you who have joined. I'm just going to share my slides. Or let's try this again. Of course, it worked in practice. There we go. So I'm presenting on the ASCO update. So this is the American Society of Clinical Oncology. So These are my disclosures in terms of my honorariums that I've received from pharmaceutical companies, as well as I'm an investigator in clinical trials. And I haven't used any generative AI to try and make my slides yet. One day I will, but we'll see how that goes. Oops. And so a lot of the talk around what happened at ASCO with gastroesophageal cancers was discussion around immunotherapy. So I want to take one step back and just discuss about what immunotherapy is. And basically, these are intravenous medications that really try to activate the immune system to attack cancer. And we're very fortunate that in the metastatic setting or incurable setting, this is being used currently for the treatment of gastric cancer in patients. And what the next two studies are looking at is there benefit in moving it into the curable setting or in patients where we can resect out the cancer? So the first study is looking at esophageal cancer. So again, just taking one step back about what is the standard treatment that we normally do for esophageal cancer. And that normally most of these patients get preoperative chemotherapy and radiation for about 5 weeks. And then they undergo surgery, which is the removal of the cancer. And then right now, for about probably the last 3 years, we do have approval for giving a year of adjuvant immunotherapy. If for those patients where there was a complete response in surgery, so there was no cancer seen after preoperative chemotherapy and radiation, so the treatment shrunk everything down and obliterated the cancer, there would be no further treatment. So adjuvant nivolumab is only given to patients where it looks like there's still cancer on the surgical specimen. That doesn't mean that there's cancer still left in the patient, though. And this study, known as Checkmate 577, was a international study, and Canada participated in this as well, where patients got 1 year of what we call adjuvant nivolumab versus a placebo. So this is how we compared things. And for the most part, the reason why this study was approved and funded was based on the recurrence-free survival, but we didn't know if there was an overall survival benefit. So do people live longer if they got this treatment? We know it can prevent recurrences, but does that actually help people live longer? So this first slide is looking sort of at that recurrence-free or disease-free survival. So these are the patients where the cancer hasn't come back. How much longer do they live? And we can see that there was a difference of about almost a year between the two arms. And this is why initially this drug was funded. Now we're looking at the overall survival. This is telling people how much longer they're going to live if they get adjuvant immunotherapy. And here we can see with adjuvant nivolumab, patients lived 51.7 months versus the placebo arm, they lived 35.3 months. Now, despite this big difference, it wasn't what we call statistically significant. So in other words, if you run the stats, it's not technically a positive study, but this is still a very clinically meaningful difference. The question is, can we figure out who's going to respond to immunotherapy? In the metastatic setting, we do use biomarkers, and this is what we call the combined positivity score, that helps us determine if some patients would respond to immunotherapy. So if this marker is positive, we actually do see a split in the curves where it does look like we can actually select out which patients would benefit. Interesting, when the marker is negative, the biomarker shows that actually do worse. Now, it wasn't necessarily powered for this, especially if you look at the placebo arm, it seems like these patients do really well, but it does show that most likely immunotherapy doesn't work when you don't have the biomarker. So maybe we can enrich for this population and spare people immunotherapy and the side effects with immunotherapy. So for the first study, there is a survival benefit when in patients receiving adjuvant immunotherapy. And while it's not statistically significant, it is clinically relevant. And maybe we should limit it to the tumors that have a CPS score greater than 1. And this is consistent is where what we see in the incurable situation is these patients that have a CPS score greater than 1 really are the ones that benefit from immunotherapy. Now we move down these gastroesophageal tract to gastric cancer. And again, we're still in the curative setting. And again, setting the stage, this is our typical treatment for curable gastric cancer where we give preoperative chemotherapy times 4 cycles, surgery, and then postoperative chemotherapy. And the Matterhorn study, which was also partly done in Canada, so this was an international study, was looking at the addition of immunotherapy drug, this time called durvalumab, which is very similar to nivolumab, just a different company. And this is where they're adding it to preoperative chemotherapy. And then they also give it for almost a total of 1 year as well after your surgery. So right now, that's looking sort of at the recurrence rate. And the secondary endpoint is to look at the overall survival later. That data is going to come out later. It just takes more time for the overall survival data to come out. And it does show that the study is positive, where the patients who got immunotherapy have less recurrences and do live longer right now with respect to getting immunotherapy. And the overall survival is trending, but these are still early days within this trial. But it does look like there is a survival benefit, or patients living longer if they get the immunotherapy arm. But again, this is still very early on. We also see with immunotherapy, we can shrink the cancer a bit more, and we can see that we almost double or triple the response rate of chemotherapy with the immunotherapy. So we do see now, moving forward, that the addition of immunotherapy, in this case durvalumab, demonstrates a benefit to decreasing the risk of recurrence. There looks to be a survival benefit, but it's still early on. So this data just recently came out in June, so it has to move to the regulatory phase of approval, so going through Health Canada. The pharmaceutical company AstraZeneca said they will try and have an access program once this happens. So most likely, we will hopefully see this available, at least through the pharmaceutical company in 2026, and hopefully formal funding for this probably I would expect probably late 2026, maybe early 2027 would be my guess. So the last abstract I'm going to present is really looking at antibody drug conjugates, and we're going to move now into the metastatic or incurable situation. So antibody drug conjugates have been used in other tumor sites, not so much yet in gastric cancer. And this is a little different than what we have used with other targeted agents. So normally in gastric cancer, we have targeted agents like trastuzumab or zolbetuximab, and this is using a monoclonal antibody to attack the cancer. Here you're using that same target, but now attached to the monoclonal antibody is the actual drug conjugate or a toxin. So that way you're almost delivering the drug directly to the cancer cell. So this is really looking at the HER2 positives, which is in about 15 to 20% of patients with gastric cancer. And Destiny Gastric 04 is a clinical trial looking at HER2 positive gastric cancers who've received trastuzumab in the first-line setting, which is our standard. And they get this drug called TDX, or trastuzumab deruxtecan, but just TDX for short, versus the second-line standard option, which is right now Taxol ramucirumab. And we can see in those patients who get TDX or the experimental treatment, there is a difference in about 3 months survival in the second-line setting. Now, 3 months may not sound like a lot, but if we look at the approvals of ramucirumab paclitaxel in the metastatic setting, that benefit was about 2 months. And we do know gastric cancer still is a difficult disease to treat, especially in the metastatic setting. So that 3-month benefit is still quite clinically meaningful for many of our patients. And this is just giving the drug on its own, so TDX. Now, it does actually have some unique side effects, which is pneumonitis, which is scarring of the lungs. And we can see, well, it tends to be higher in breast cancer patients. It's not as bad as we anticipated that we thought it would be in gastric cancer patients, mainly probably because we don't have as much radiation in the chest. And the grade 1 or grade 2 events are actually probably around 10%. The other things we worry about HER2 drugs is whether we affect the heart, and we can also see that rate is still pretty low. So TDX has actually undergone an experiment within the Canadian Drug Agency. So the Canadian Drug Agency is the federal agency that reviews all of these drugs. So it gets Health Canada approved, goes through the Canadian Drug Agency about should this drug be funded or not. And this is why in Canada it does take time for things to get funded. And they've come up with this time-limited recommendation. So companies can put in the early phase, so before the phase 3 is read out, the phase 2 data that shows the signal if the drug is working. And then they have 5 years to complete the confirmatory studies. And TDX actually was already going through this time frame. And we can see actually what has happened was this drug is actually currently approved and funded now and rolling out in all the provinces. And we just got the phase 3 data. So here, Health Canada has approved this back in January. the Canadian Drug Agency made their recommendation. There was already pricing negotiations for this drug. And Ontario actually has listed this as of May. Other provinces are still working on the launches. This happened much faster than anticipated. But right now, even as normally, if we look at the regular how this would work, we would have had this data and probably would not have this drug available to our patients, at least through an access program, not for at least 6 to 8 months, and probably not full funding for at least another year and a half, almost 2 years. So here we have now already access to this drug for our patients based on the early data. And then hopefully with this phase 3 data, Health Canada and CDA will now make this, instead of a conditional recommendation, now move it more formally. So I think the government processes have been listening to patients about trying to get a process to get access to drugs much sooner. And this is an example of how now this drug is going to be available and fully funded for our patients, because I think this drug is about $20,000 a month. So, and with that, I will stop because I think the questions are at the end. So I will stop sharing, go from there.
Thank you so much, Dr. Lim. So yes, in terms of some housekeeping, we will leave the questions to the end just because we do want to engage all our speakers in a panel discussion. For those of you joining us virtually, please do type any questions in the chat. And then that way we can also read out the questions in case you're feeling shy and don't want to be on screen as well. Okay. And I would like to say that ASCO is a wonderful conference. With most of these conferences, actually, historically, it was something that only either surgical oncologists or medical oncologists were invited to. But in recent years, they've really engaged patients, so patient advocates. So I had the pleasure of actually being at ASCO and engaging with a lot of the patient advocacy groups that help patients with gastroesophageal cancers. It's a wonderful place to network, so get to know people that have been affected by the disease. And it's also a wonderful opportunity to meet some of the smartest minds in all of the world working on gastroesophageal cancer medications and improving the science and lives of patients. From then on, we will now move on to our next speaker. And the next speaker is Dr. Natalie Coburn, who will present some highlights from the International Gastric Cancer Congress.
This is a great segue. It's perfect because that's what I wanted to talk about is the engagement of patients and patient advocacy groups. So the International Gastric Cancer Association is largely surgical based, unlike ASCO and ESMO, which are more medical oncology based. So this is a largely surgical based group. And so these fancy randomized controlled trials that the medical oncologists talk about don't exist so much in the surgical group. But I want to talk about what I really felt were the themes of the meeting that we had in Amsterdam. And this group meets every 2 years and meets internationally. I think it was really about collegiality and meeting all of our colleagues from across the globe. Here's some of the folks from the UK that we were talking with. And Teresa had a fantastic stand right in the middle of all the action and had lots of visitors talking with them about my gut feeling and the work that she and Katy and this group's doing. So the meeting was in May. It happens every other year. In 2 years, it's going to be in Santiago, Chile, and then 2 years from that, it will be in Korea. And then who knows where it will go next. It rotates around the world to very nice places. And I do think that they're really trying to engage the patients and the advocacy groups more. And we'll talk about that if I can make my slide advance. So in terms of scientific updates, I would say the meeting was just a lot of updates. There weren't a lot of groundbreaking randomized control trials. So they talked about some of the ongoing international trials, and there's several important trials looking at surgical technique. There's some trials looking at surveillance and what the ramifications are of surveillance of patients. And in many situations for cancer, all the surveillance that we do, it actually doesn't change anything at the end of the day in many situations. So, and makes people quite nervous. So there are active trials going on for that. There was a lot of discussion about immunotherapy and the trials that Dr. Lim discussed and the trials that I'm sure Dr. Gill is going to discuss shortly. And then updates on the Japanese gastric cancer guidelines. And the Japanese surgeons, because they see so much more gastric cancer than most other countries, really are the ones who are pushing forward in terms of creation of guidelines for surgery and looking at the evidence for moving into minimally invasive and where that makes the most sense and maybe where it doesn't make the most sense. But I think the thing that really struck me about the meeting the most was the collaboration between the countries. And two of the main topics that were discussed in the main keynote speeches were about care within the Netherlands. Vivian Strong gave an overview about care within the United States. And then Franco Roviella gave a talk about the Italians. And I would say the Italians are a very interesting group for the Canadians to model themselves off of because it is a smaller country and gastric cancer care was spread out across the country and across all small hospitals about 25 years ago. And they really worked very hard as a country to bring everything up to standards, to Japanese standards, and to improve the volume outcome relationship for those hospitals. And now there's some of the surgeons who are leading some of the major clinical trials. The other thing that was discussed a lot was comparison of results between countries and regions so that we know that within Canada, we are providing care that is equal to or superior to most other Western countries. And within different regions of Canada, that we are providing equal care across the country. And that's something that we're working on as a research group across the country. In terms of the structure of the IGCC, it's an international group, and you know they're slow to move forward sometimes. I'm sure they wouldn't mind me saying that, but they are working on creating committees that are more project oriented, and this is one of the things that the council has decided that they want to push forward. So you can see there's a whole host of projects that they're working on that are on the left side. And then on the right side, these are the new working groups, which is multidisciplinary tumor boards, gastric cancer prevention. And this is a collaboration with the International Association of Research on Cancer and the World Health Agency. So a really powerful group. And of course, worldwide gastric cancer is quite common. And so this is a very important collaboration. And then what they're calling habilitation, but I think they're rolling into this rehabilitation after surgery and prehabilitation before surgery and while people are going through chemotherapy prior to surgery. And we know from the colorectal cancer literature that exercise around the time of a cancer diagnosis and around the time of surgery and while people are on chemotherapy is really quite critical. The group in Dublin has a significant amount of experience in prehabilitation for esophageal cancer, and so they're the ones who are going to be leading that. Then I put down here patients, and Teresa has been the representative on council for the patients, and they've also asked for me and Teresa and the Canadian team to work on leading the patient advocacy group and bringing all the patient advocacy groups together so that that voice can be heard and heard quite clearly and loudly. In terms of what the Canadians presented, we were highlighted throughout the conference as a group that's very engaged. These are all the posters that the Canadian teams presented, and one of my students made a nice little website if you want to look up the Canadian projects. And then the other thing that was quite different at this meeting compared to meetings about 10 years ago was the presence of My Gut Feeling and the presence of the patient advocacy group, not only the Canadians, but also UK group and some of the other international groups, talking about the symptoms around the time of surgery and what that surgery and chemotherapy and the treatments mean, but also what's important for them as we move things forward. So there was a lot more discussion of quality of life. When Dr. Lim talked about the results for the trials, the gold standard of how most trials are created is to look at survival, because that is something that obviously is quite meaningful. But in most trials these days, quality of life is also a secondary endpoint. because we know that that's important, so that the side effects with all these treatments are sometimes quite significant. And we want to make sure that we're measuring that as well, both on the surgical side and on the chemotherapy, immunotherapy side. So I think that is my last slide. Yes, and I will pass it over to Teresa, who can talk about what she presented there. And I'm just going to go off video for a few minutes.
So, hi everyone. For those of you who don't know me, I'm Teresa. I'm the chair and co-founder of My Gut Feeling. We were lucky enough to be part of the IGCC in May in person. And what was really special was that, in fact, we were the first organization actually to speak within a scientific session. So we've done other things in the past at this Congress. We did the first working group, and then we worked with a number of the American associations and the Japanese association and the Italian association, and we've had sessions in Houston, and then we've had sessions in Japan, but those were specific patient advocacy sessions. So this time they invited us to speak within the scientific session, which was a little bit overwhelming at first, but it was great because for us, and I think for all of us as patients and as survivors, we were able to, as Dr. Coburn said, we were able to bring the patient voice to the forefront and really speak about what the patients go through and what stomach cancer and how stomach cancer impacts our quality of life and what is actually impacted. And that's really all, thanks to all of you. So this is just what I'm going to be speaking about. So this is very similar to the presentation that I did give. I've just edited it more for this webinar, but it's pretty much the same presentation that I gave. So this, as we all know, that stomach cancer is often diagnosed at advanced stages, especially in the Western world, including Canada and US. And that stomach cancer typically is asymptomatic in the early stages and is often misdiagnosed as other disorders such as IBD or GERD. And really, there are no formalized screening programs for stomach cancer, unlike colon or breast cancer. And so this is what we as patients are facing. And so the way, this is just a slide to kind of differentiate how the patient looks at the journey and how the caregivers look at the journey. And the caregivers, the healthcare providers, and in general, people look at the cancer journey or the stomach cancer journey as a more linear event or journey, whereas those of us that are in it go through it as we get diagnosed, it becomes more of that squiggly line, and it's all over the place, and impact on our quality of life and what we go through is not linear at all. So what we did, Katy and I worked on this together, and so what we wanted to do was to send out a survey to all of not only our members but to patients and survivors and caregivers internationally. And so we sent out a survey via email and online to the online communities that we're members of. We ended up with over 115 patients, survivors, and caregivers, as I said, internationally, respond. And these two figures, so the circle shows where the response is, and so as you can see, most of it is from North America, but we did get an international response, and you can see that the gender is, there were more females than males that responded. So this is just more statistics, just general statistics from the responses. So more than 50% were actual survivors. So we look at survivors as those that are undergoing treatment as well as long-term survivors. And so we had over 50% that were survivors. And at the time of diagnosis, over 62% were under the age of 60. So that's quite telling. As we have seen in the last few years, that people are being diagnosed not only with colon cancer earlier, but even with gastric cancer. I mean, we see it. We see it in our groups. We see it in the online communities, and so just from the response that we received, you can see that in fact there is that trend. These are the stages where people were diagnosed, and you can see that together both stages, the later stages make up more than half, and then the length of treatment, those with the lowest amount of treatment time are basically those who just were at the earliest stages and went through like surgery, and then it just increases. So these are the types of treatment. This is, and again, these are all responses from all of you. So we cannot thank you enough for continuing to be engaged, because we feel this is so important. And this is what I presented to doctors from all over the world. So of course, surgery, chemotherapy, radiation, a combination of chemo, radiation, immunotherapy alone. You see where where it and you see where the chemo and immunotherapy comes in at about 21%. So this one is about, whoops, sorry. Okay, this is about the overall impact on quality of life of stomach cancer. And we went out to patients, long-term survivors as well, and caregivers who were bereaved. So both caregivers with living loved ones and bereaved ones, because we felt that especially the bereaved caregivers are really a sector of the community that often is overlooked. And in general, caregivers tend to not get the not get the attention and what they go through. And Katy mentioned this, I believe, caregivers go through a completely different type of trauma. So this is the impact, and you can see that no matter who and no matter what it was, that quality of life has been significantly impacted. This is during diagnosis, long-term, you see that it's over 50%. During diagnosis, it's much higher. And then you see with the bereaved caregivers how they've been affected. And so this is the physical impact, and these are the answers that we provided. And of course, we see once again that there was there's an incredible impact on life. And then this is all the actual physical impacts that occur. And as we know, appetite changes and weight loss and nausea were at the top of the list. This is one that we felt was really important to talk about. It's often not really talked about. People don't like to share about this, so we're quite happy to get responses about this, because it's a discussion that happens in smaller groups. But it was good to see that people did respond. And as you can see here again, there was between some financial impact and a significant financial impact. It's almost it's 80%. And the leading causes were that people had to take time off work. Some people had to go on short term, others were on long term, some people had to stop work altogether. I'm one of those people. Bank loans, all of the above. And we really felt it was important to put this forward to the people at IGCC, to the attendees there, so that they could see exactly what, it's not just the physical or the side effects from chemo. There's so much stress that is put on both the patient and their caregivers and the entire family. This is the psychosocial impact on the quality of life, as for stomach cancer, for the stomach cancer community. And again, you see how high it is, and you see what you answered, which was not feeling included in the discussions, depression over not being, sorry, these are a little bit chopped off, but anxiety, anxiety, depression, those were the top ones. And also not feeling included in their healthcare plans, and the anxiety of recurrence. So we also, part of this survey as well, is we wanted to get direct quotes from patients. And so the big question was, how has stomach cancer impacted your quality of life through diagnosis, survivorship, or as a caregiver? And also we asked, what are the gaps in support and what can we do forward? So in the following slides, and I'm not going to read all of the quotes because there's too many, and this is being recorded, so everyone can go back, and if you want to read the quotes, because some of them are incredibly impactful, and they just hit everything that we go through right on, they're right on target, because it's our voice. So all these quotes are direct quotes from those of you that responded to the survey that we ended up presenting in May. So, sorry, this one, this is the biomarkers. So we did ask the question on biomarker testing, and you can see that half did get tested, but about close to a third didn't, and about 20% didn't even know. And the issues are access to biomarker testing, and results from biomarker testing are not always available. And oftentimes patients have, they said, well, I know they did it, but it was never reported to me. So, and these are some quotes. Sorry. Some of these. Sorry, I'm going the wrong way. Okay. And so those are quotes. We also asked the type of biomarkers that had been tested, so you can see the list there. And this is, of course, the we asked about diet and nutrition, and, the issues, of course, are insufficient diet resources, referrals, and staffing, and cancer, cachexia, and the poor prognosis. These are some of the quotes that we received from you. Just for instance, Patricia, I was given no nutritional support, no help with figuring out a plan for nutrition needs. So 14 years ago, when Katy and I were both going through this was one of the big things that I know we dealt with. And, it's hard to see that this is still going on for patients, that they feel that they're not getting this type of assistance. What we try to do, and I know the other organizations try to do, is we have quite a lot of resources on our website about diet and nutrition. These are two examples. Cooking with Joy and Digesting with Ease, and that was a recipe book that we did a few years ago that is amazing. The other one is another recipe book, and we have a fairly new one, and it is about eating well and living well. So it's more about going through things, and it's got different tips and different health tips, and it is available in English and French right now on our website, and we're hoping to have that available in hard copy, hopefully within the next couple of months. So this is the psychosocial support, and for us, this was one of the main reasons I think we started My Gut Feeling. It was the support element, because we felt that when we were going through it, there was nothing there for us. This was 14 years ago. People didn't know anything about stomach cancer, and so we started off this organization as a support group, and we've continued that. And we've seen over the years that it's become so much more important in terms of being talked about and being spoken about within different groups online. But still, there are insufficient resources or referrals. Not everybody can get access to either a psychotherapist or a psychiatrist. But we feel that this is truly so important to the quality of life for patients. And you can read some of these quotes. And the picture here is of a mother and daughter. They're actually Canadian. And the first picture is the daughter, who was quite young at the time when her mother, who was diagnosed with CDH1, had her surgery. You see the daughter holding, just supporting the mom, and then there's the reverse. And the daughter, Mika, has just also was diagnosed with CDH1, and just received, just had a total gastrectomy at 15. And so now the mother has, so they've done dual roles, both as patient and survivor and as caregivers. And actually, just to note, both of them will actually be presenting at our conference in November. It's an incredible story within their family, but it also speaks to not only family support, but just general support through groups. And if you're not a support group person, a one-on-one, a friend, a partner, we don't always say that we're the only way to go, because there are different ways of getting the support. This is how cancer impacts every aspect of life. And here are some quotes on financial and social life, which I know for me personally, it totally affected both of those. And the picture here, at the time when I presented in May, Rachel was going through her 5th line of treatment. Unfortunately, she passed away in June at 37, which was a great loss to the community, as she herself was an incredible advocate. And both Katy and I thought that the poke that she gave us was pretty incredible. So she said treatment and the effects of treatment make quality of life difficult to manage. Stomach cancer steals our present as we are striving for a future. We are fighting so hard for more time, but also balancing, trying to live every moment. And I think at some point in our journey, we all feel that. And, you know, when we asked Rachel to give us hope, and she just, you know, she just gave this to us like immediately. And I just thought, oh my God, she's just captured what we've all gone through at different points in our journey. And she was an incredible young advocate and an amazing friend as well. And of course, our supporting caregivers. And so, of course, as I said, we deal with caregivers who not only, you know, their loved ones are still living, and it's a long journey. I can tell you, I've been on it 14 years, and my husband's been through everything with me and the long-term side effects. And then there are also the bereaved caregivers who are so, you know, so traumatically impacted, because this is a disease that takes so much away from you. And so I don't think I can manage to read these quotes. So I invite you to either read them now or when it's up on our YouTube channel, please do go back to these. And those are just some images of my support team. And this is on long-term survivorship. And this is again one of the issues that we deal with all the time. People beyond the 5 years, where you kind of get you're no longer seen on a regular basis through your oncologist unless there's a very specific reason. And so I know a lot of us feel that we're kind of, I remember feeling like I was being fired by my doctor, and I managed to eke out an extra year with my medical oncologist, but because I have Lynch syndrome, I'm still surveilled, but so many others aren't surveilled. And some of the issues that we deal with are, you know, the whole issue of weight. That never goes away. Vitamin deficiency, chronic fatigue, so those are the issues. Whoops. And then here's some of the gaps that people said they saw in their healthcare and their support. So one of the biggest one was clear communication with their healthcare teams, and then treatment options and nutritional information, and then the psychosocial support, and then accessibility to treatment. And these were the gaps, and these I think are gaps that we all have been, you know, in my role as, you know, patient advocate and as chairman, you know, as part of my gut feeling, we try to work on these, but and speak to the healthcare teams about this and provide that nutritional information, because we're all, you know, we're around 24/7, but also it's still, you know, I keep saying 14 years and we still have these issues. And so these are issues that we felt that we had to speak about and make those that were in Amsterdam aware of what the patients and survivors and caregivers go through. And this is just some more gaps and what we can do going forward. And I think it's about, you know, we always say it takes a village for different things, and, you know, not one support group or not one advocacy organization or not one, you know, doctor can be everything. It's about closing, you know, bridging those gaps, closing the silos so that healthcare teams work together and that the patient is part of that team. You know, and it's about referring patients to the proper, appropriate specialties like dietitians and psychiatrists and social workers. And then, of course, we always ask our doctors to be our advocates as much as we do our own advocacy as patients, but we always, you know, I know I always go to my doctor to help me to advocate, you know, when there's something that pops up even 14 years later. And for us, this is just our board of directors and our volunteers. Sorry, that's just my little news feed. Just makes me smile, so I include her in everything. And so the next few slides are really quick about how we were involved in IGCC. They're just some images that just showed you what it was all about. Some scene. It was a great networking place, great learning. I totally agree with what Natalie said in terms of the collegial element of it. It really was about, everyone was talking about working together more. And this is not just, you know, patient advocates. These were like doctors from every corner of the earth. So that was incredible to see. And we had great engagement at our booth. So we were quite happy about that. These are some of the speakers. And that's it. Thank you. And so I am going to pass it on to Dr. Sharlene Gill, who will update us on ESMO GI.
Thank you. Thanks, Teresa. I'm just gonna just put this into, all right. So so thank you so much. I continue to can you see it? Yes.
Yes.
Okay, good. All right. So you know, Dr. Lim talked about the American Society of Clinical Oncology meeting. Natalie and Teresa Dr. Coburn and Teresa talked about the International Gastric Cancer Conference, and I'm going to be talking about ESMO, the European Society of Medical Oncology. And they have a specific GI cancer symposium. They have an annual meeting every year that's usually in the fall. But just earlier this month, they held their focus on GI cancers, their GI cancer symposium. So my name is Sharlene Gill. I'm a medical oncologist based out of BC Cancer in Vancouver. I work with Dr. Lim. That's how I introduce myself typically. So these are my relevant disclosures for this discussion. And you know, the ESMO GI conference is a mix of educational content for GI cancer care providers, you know, from across the world. It is mostly a European contingent, but there, you know, there's representation from the North and South America and from Asia as well. And so I focused on two sort of oral abstract presentations rather than the educational content, sort of what might be new data of interest. And the first one of the two is actually Dr. Lim laid a lot of the groundwork for the sort of explanation around the role of immunotherapy in this setting of when we have someone who has what is a resectable cancer of the stomach or the gastroesophageal junction, and where we now give perioperative chemotherapy, so chemo pre and post surgery. Matterhorn was a trial that looked at the role of adding immunotherapy with an agent called durvalumab, a PD-1 inhibitor that you heard about earlier. So at ESMO, they presented the patient-reported outcomes from Matterhorn. So Teresa talked about quality of life when we think about, you know, the patient experience. And so patient-reported outcomes are increasingly embedded in clinical trials where, yes, we're trying to identify, you know, what is the benefit? Do patients live longer? But also, are they living better? Or at the least, is that increase in survival coming without a cost to quality of life? Is their quality of life being maintained despite that new increased treatment? So just a reminder, and because we did discuss this for the ASCO update. So at ASCO, Matterhorn's primary endpoint data was presented. So this was a randomized trial in almost 1,000 patients from around the world to receive standard of care, current standard of care, which is FLOT chemotherapy before and after surgery, controlled with a placebo compared to an experimental arm of FLOT plus durvalumab, which is, as you heard earlier, is an immune therapy agent. And what was to kind of look at sort of just the distribution of the patients who are on Matterhorn. This included patients with stomach, so gastric and GE junction cancers. 70% of patients had gastric cancer. About 20% of patients came from Asia for this trial, the 80% from rest of world. And as you also heard, and as had been presented at ASCO just a month prior to this meeting, Matterhorn did demonstrate a statistically significant and a sort of this meaningful improvement in event-free survival. So, you know, an almost 30% reduction in risk of an event, which in this case was recurrence or death, with the addition of immunotherapy to the current standard of FLOT chemotherapy. As you also heard, the overall survival is trending to be better, but has not yet reached statistical significance, and that may come with more maturing of this data. So what was the new data that was presented at ESMO GI a few weeks ago were the patient-reported outcomes, which were a pre-planned endpoint for the trial. And so when we talk about quality of life and trying to measure it in a study, usually what's applied are validated instruments, which are tools or questionnaires that have been designed to try to identify changes over time in different dimensions of quality of life. So GHS is your sort of our global health sort of score. Physical functioning refers to the ability to do sort of activities involved in daily life. Role functioning is the ability to fulfill social roles in life, and then disease-related symptoms. And they were assessed by two different questionnaires. So one was the more global cancer questionnaire. It's called the EORTC QLQC30. And the second was a questionnaire designed more specifically and validated in patients with gastric cancer. These patient-reported outcome dimensions are scored from 0 to 100. And generally, when you look at them, we want higher scores. We want to see higher scores for the quality of life and physical and role functioning metrics, and lower scores for symptoms, right? Lower symptom burden, the lower score. And according to how they're validated, a decrement or a decrease in quality of life by greater than 10 points, so on the score, or an increase in symptoms by greater than 10 points it would be called a deterioration in quality of life. Okay, so the first thing you kind of want to look at is over the course of this trial, which involved an intervention, a treatment that was given over a year, so that translated into 14 cycles, you know, what was the patient's ability, the subjects on the trial ability to complete the questionnaires fully. And so they actually, you know, we call that compliance. So they were able to show that there was actually, for both those tools, both the questionnaires, there was, you know, very, very good compliance. So, you know, 80 to 90% compliance and completion rates up until, you know, the end of study. So that's really impressive. And at baseline, you know, when patients were enrolled in the study, there were fairly comparable baseline metrics for their, so on the EORTC QOQ-C30, they had these 3 measures for global quality of life, physical functioning, and role functioning. And then the symptom scores primarily came from that second gastric cancer validated questionnaire. And they were pretty similar in both groups. And what they demonstrated or showed at ESMO GI was that over the course of the study, the addition of durvalumab, which did translate into this improvement in event-free survival, did not cost the subject or the patient a decrease, a deterioration in quality of life. So adding the additional treatment didn't adversely affect their quality of life score over time. So you see those scores are the same. It also didn't improve quality of life, and this was to remind you an adjuvant study. So meaning that patients, for the duration didn't have known active disease. So it's, sometimes in other settings for advanced cancer, we would like to also see that maybe, quality of life is improving because you're controlling symptoms better. But this is a different population, so this is not an unexpected finding. So that's good. You get a better survival outcome, event-free survival outcome, without costing quality of life. And likewise, in terms of the time to deterioration in these patient-reported outcomes, they were statistically the same in both groups. So receiving durvalumab didn't mean that patients had a more rapid deterioration in these instruments. If you look at the 3 rows that are in gray, there's a suggestion that the quality of life might actually be a bit better with durvalumab, but not statistically significant. So this is important data to sort of show that in this setting where patients are having perioperative treatment, the use of durvalumab with FLOT chemotherapy not only improves event-free survival, but does so without any difference or with preservation of their overall quality of life. And then the second abstract I was going to talk about was focusing on a specific biomarker. Teresa alluded to biomarker testing in esophageal gastric cancers, but a specific sort of new kid on the block, which is Claudin 18.2. So Claudin 18.2 is a protein that sits normally within the lining of the stomach, and it kind of sits within sort of these, it's kind of buried in the tight junctions in the stomach. So in an intact lining, normally Claudin 18.2 isn't really exposed or accessible, like you can't bind a protein to it because it's kind of hiding in these tight junctions. But when we have a stomach lining affected by cancer, this target becomes exposed, and then potentially accessible to be targeted with an antibody treatment. So we know now that this can be targeted with an improvement in outcomes, and that's been demonstrated with an agent called zolbetuximab, which is a monoclonal antibody that targets Claudin 18.2. And there have been 2 randomized trials, this is one of them, that have demonstrated that when you add zolbetuximab to upfront chemotherapy for patients with an advanced, so metastatic or unresectable stomach cancer or GE junction cancer, that for cancers that express Claudin 18.2, you can improve survival. The definition of Claudin 18.2 expression for the purposes of this agent of zolbetuximab is that you see this expression in greater than 75% of tumor cells. And so that is in about 1/3 of the population, okay? And so this is an example of the survival benefit that has been seen with zolbetuximab combined with chemotherapy, a 25% sort of proportional reduction in risk of death over time. And as a result, this is Health Canada approved and soon to be publicly funded, but an available option for patients in Canada who have Claudin 18.2 positive esophageal gastric adenocarcinoma. So what was presented at ESMO GI was a very early study, so a phase 1b study looking at another way of targeting Claudin 18.2. And it's with an agent called Givastomig. So Dr. Lim talked about antibody drug conjugates as one sort of type of way of targeting. So zolbetuximab is a monoclonal antibody directly targeting. Antibody drug conjugates are where you have a target that you identify, but conjugate it with something that will kill the cancer cells, typically chemotherapy. A bispecific antibody is an antibody that's engineered to be able to target two targets at the same time. So Givastomig targets Claudin 18.2, and it also targets something called 4-1BB, which is an immune modulator, and it leads to more potent activation of the kinds of T cells in our immune system, our killer T cells. And the hope is that there's synergy there in that combination. And so, this phase 1b study, which is very early data, got a lot of attention at ESMO GI. A phase 1b study is typically a study trying to identify safety and optimal, what's the optimal dose. So the way this study was designed was that they were looking at combining Givastomig with standard of care chemotherapy, which standard of care treatment, which is chemotherapy with FOLFOX plus immune therapy, and then adding this agent. And they added it slowly at different dose levels to ensure that they could dose escalate safely. And the other thing to highlight is that the patients who were eligible for this were patients, who had Claudin 18.2 positive, but in just any Claudin 18.2 positive, so greater than 1% of tumor cells, as opposed to the 75% threshold I talked about with zolbetuximab. It also included patients who had any PD-L1 expression as well. And so the first thing that was commented on was that as they tried to increase the dose, they didn't encounter any dose-limiting toxicity. So the proportion of there were side effects that were observed, we'll talk about that, but they didn't increase with the increasing dose. The second thing to highlight is this is very early data. There's 17 patients in this study that are being kind of reported on, and that's kind of the qualifying statement. And then in terms of the side effects, we kind of worry about nausea, vomiting with this class of agents that was seen, but not at a rate that was higher than what was expected. And then the other ALT, AST refer to liver enzymes being increased, and that with this bispecific, the immune modulatory component has been shown sometimes to increase liver toxicity, but that hasn't been observed yet in this early phase study. And so the reason it got some attention at ESMO GI was because of the response rate. So they observed a 71% response rate in all the 17 patients combined across these 3 different dose levels. If you look at this table, the patients who were on the higher dose levels, 8 and 12, which was milligrams per kilogram, which is 12 patients, the response rate was 83%. And that responses were seen even in those patients who had lower than what's defined as Claudin 18.2 positivity, less than 75%. And so that's, I think, where the opportunity is felt to lie here, is that if this agent continues to show promising efficacy, is this something that could be considered for patients who have low Claudin 18.2 tumor expression. The responses were described as rapid, so the onset to a response was typically within the first 2 months. They were described as deep, so that's what this spider plot on your left shows, is that in many cases there was, complete reduction in tumor volume, and they were durable. And that's kind of, if you look at this last line, which says the proportion of patients who had no progression at 6 months, so PFS of 6 months, was sort of 80% in the 8 and 12 milligram group. Again, very small numbers of patients, for a phase 1b study. But the study is being, expanded, and again, I think it speaks to a lot of interest in Claudin 18.2 as a new target. So we have this data from this Gavastomig bispecific that we just talked about, zolbetuximab, already approved in this setting. But there are studies looking at Claudin 18.2 targeted in different ways through CAR T, through antibody drug conjugates. And so I think there is, more to come in terms of, being able to use Claudin 18.2 as a target to improve outcomes for patients with Claudin 18.2 positive stomach cancers. And so with that, I will stop sharing. I recognize we're kind of over time here, but happy to take any questions if there are any.
So thank you so much to our speakers. So for those of you that have questions, please do type them into the chat box and we will ask them to the group. There's already a couple of questions that I see. So I guess I'll kind of start off by asking both Dr. Lim and Dr. Gill, do you feel that there is a delay in drug reimbursement in Canada relative to the rest of the world or the United States? Basically, the question is, how long is the delay typically between FDA drug approval versus when things are funded or accepted by our Canadian universal healthcare system?
I'll let Howie comment because he comments.
Yeah, there is a delay, and but it's mainly because we have different systems. So the FDA is similar to Health Canada in the sense it's the regulatory body that looks at just the safety and efficacy of a drug. And in the United States, once the FDA approves something, it can technically, a patient can either buy it or an insurance company will cover it depending on your insurance coverage. So because we're a single user pay system where the government's paying for the drug, it has to go through a separate process called the Canadian Drug Agency and then pricing negotiations. So it can take up to an extra year before it's fully funded. During that gap, pharmaceutical companies often will step in with patient support programs to provide free drug to bridge that part. In both systems, the drug cannot be available until it's actually gone through the regulatory like FDA or Health Canada. Health Canada has partnered with FDA with various projects so that we can expedite that approval process since the data is the same. Given recent politics, I don't know how that process is working in terms of partnership, but hopefully it hasn't been affected by by the current administration, because I think the FDA itself is undergoing issues. With respect to Canada, it would be better to compare us to like European countries where they're regulated by the EMA and so we're probably on par with some European countries. There are some countries like Germany where they get things out faster. They'll fund it initially and then work on price negotiations simultaneously. So there are variations in that. So it's a complicated question though, sorry.
Sorry to put you on the spot. I guess just to that point, we do get a lot of people saying, how can I participate in patient advocacy, right? So although oftentimes Teresa and myself were the face of my gut feeling, there's a lot of patient advocacy that goes behind the scenes. And Teresa touched upon some of it from the survey that she presented. So that is patient advocacy. Those are real people, real patients, real caregivers talking about their journey, educating others, making others understand their journey, and making other people feel included. So one of the other ways that you can be a part of patient advocacy is by helping my gut feeling with surveys to the Canadian Drug Agency, or the CADTH or CDA, because as Dr. Lim said, there's a lot of science that goes behind drug approval, but without the patient voice, a lot of these drugs would actually not be approved. So if you're interested in participating in advocacy, certainly let us know. And when we have the next CDA submission, we will engage you and provide you a survey so that your voice can be heard, so that the government knows exactly why you think certain drugs should be approved. So thank you very much, Dr. Lim.
And Katy, that's a really important piece, is the patient voice is really important in these CDA negotiations. I've sat on the other side for CDA and they really do listen to what the patient voice is and how it impacts them, because they don't they look at something, well, yeah, is 3 months really that valuable to a gastric cancer patient? Yes, it is. It's really valuable, and that comes out in what you submit. So that it is really crucial. They actually listen to patients more than they do to us, to be quite frank.
That's lovely to hear. I think, you know, one of our mission statements through My Gut Feeling is empowering patients and speaking up on behalf of the patient voice, right? So that's very lovely to hear. Thank you. There's a couple of questions. Oh yeah, sorry, go ahead.
Sorry, just to add on to that. So for those of you that are in the US, or anywhere, we always include the international patients when we do send out a survey for the CDA, because we like to get, you know, a good sense of it. And so please don't feel that if you're outside of Canada, you can't answer. I think that it's good input, especially because most of like in the States, you may have access to the drug that we are trying to get the approval for, or that is going through this system, because it is quite a process. Both Katy and I know that it is quite a process. So you guys had answered and participated in the past, so that really is the advocacy at work. So did you want me to read out the next question?
Sure, go ahead.
Sure. So there has been lots of discussion on patient support groups for gastric cancer about the use of continuous glucose monitors. I found 2 small research studies in Japan of the use of glucose monitors, and especially the changes in blood sugar that happen with different types of surgery. Are you aware of any other work being done in this area? And I will put that out to anyone. This is quite a big topic in like the support groups, and I do know a lot of patients who have had gastrectomies are now wearing the glucose monitors, and so I think it's something that patients are quite interested in and want more information on. So
yeah, Teresa, I think I can address that. Sorry, I'm just a video off. So yes, that is an area that is under researched. I can say that very confidently. There's not a lot of research in that area. And I think certainly it's something where the patients again are leading and highlighting this as an area where we do need more research. So no, there is not a lot of evidence. This is some place where I think future trials are very necessary. And I think it's one of those places where technology has advanced to the point where it may be useful. So if you think about the way glucose was monitored even 5 years ago, it probably would not have been that useful for gastrectomy patients. But the newer monitors and the new generation monitors are certainly much better, and certainly better able to pick up swings in blood sugars. Now, whether swings in blood sugars relate strongly to swings in how people are feeling is another thing that really needs to be studied. So it's certainly something that's been highlighted to our group through the Canadian Cancer Society grant that we're working on with My Gut Feeling. And so probably you'll be hearing a lot more about that over the next few years, hopefully from our group and from My Gut Feeling. But somewhere the research really does not exist in the way that it should. So I keep bringing this up because it's something that's on the horizon.
Thank you. We look forward to learning more about that. That's definitely a very important quality of life measure, I think. For any of us that live without a stomach, myself included, I typically do fluctuate with hunger whenever I don't eat, whenever my blood sugar goes low. You know, there is a noticeable mood change for me, at least. And oftentimes, you know, I did not recognize what that meant until I realized, oh, wow, my blood sugar is low, when I had a bit of a scary episode at work, actually. So it's certainly something that impacts the quality of life of patients, and definitely something that needs to be studied more. And Dr. Coburn, or any of the other panelists, there is a question again about surgery. Can someone address how much is absorbed by the body after a total gastrectomy? I read somewhere that it's 30%.
I think it depends on 30% of what. In terms of calories, most of the calories will be absorbed. In terms of B12, I find patients are quite variable, and some patients do fine taking B12 and iron for pills, and then some patients do not. And they've all had a total gastrectomy, so they should all absorb about the same amount, but they don't. And so I think everyone's just a little bit different. The other thing that's been highlighted quite significantly by the MD Anderson group is bone density. And patients after a total gastrectomy are much less likely to absorb calcium. So even though you're taking calcium supplementations and vitamin D, you're at risk for osteoporosis and osteopenia. And that's going to be one of the major things that we will be writing about as we start summarizing our Canadian Cancer Society grant that Teresa and Katy are both leaders on. So B12, iron, and calcium, along with vitamin D, are the four things that are most important. And then obviously some people absorb better in terms of calories and micronutrients than others. And we're working to pull together a summary that's easy to digest, because most people's family doctors don't have a lot of, maybe they have one patient with a gastrectomy in their entire practice. So their ability to have in-depth knowledge in this area is limited, because their practice is so broad and they have so few patients with gastrectomies. So we're working with the patient teams, and I'll put a plug in as well. We will be looking for patients to start to look at everything that's published out of this grant, to make sure that it's accessible, that it answers the questions appropriately, and that we have the information that's needed there. And there's some things where we don't know the answer, like continuous glucose monitoring, and then that will form the next project, is how to use that. How do we use that technology best? And so we'll look to your teams and you guys to help us with that.
Thank you.
Dr. Gill or Dr. Lynn, do you have anything to add to that? And as Katy was saying, I think that it's an issue like early on in your journey, as well as years and years, as you get further away from the actual gastrectomy. I think that is one of the issues that is really important on quality of life. And so I would like to get like the medical versus a medical oncologist, just your input on that.
Yeah, maybe I can speak to it. I think in the context of patients who've had surgery, and then we're trying to think about offering, asking them to do additional treatment, whether it's chemotherapy or in like Matterhorn chemoimmunotherapy. I mean, optimizing whatever we can control so that they're in the best status to be able to safely receive that treatment is really important. In my clinical experience, I haven't had a lot of patients actually asking me about continuous glucose monitoring, and perhaps they think, oh, she's a medical oncologist, what's she going to know about CGM, which is understandable. But I agree with Dr. Coburn's point earlier, is I think there is really an opportunity to build some evidence here and provide some research and try to measure what are the benefits is it a quality of life benefit? Is there actually benefit in terms of nutritional measures and functional measures? Because we do need that data, but that what I do know is that patients after surgery are struggling with so many issues that if there are parts of that we can control, and there's a way of controlling it, we really do need to, push that needle forward.
Yeah, I agree. I think also, honestly, the CCS grant that my gut feeling has helped push is going to be a huge help, especially with respect to the nutrition and getting that information out. I think it's also variable from patient to patient. Some patients post-surgery, their stomachs or the small intestine reaccommodates. It depends on the type of surgery, how they've, and like, I know Christine Bresden loves IV iron, but I do find some patients respond to oral iron, and I don't have to send them for IV iron, and so everyone's a bit different. And the great thing is with the technology now, continuous glucose monitoring, that can really help patients. I mean, there's all this new wearable technology that can help people with that survivorship piece, which I think is actually really cool and important to move forward with as well.
Okay, and I think we have time for maybe one more question. So kind of bringing together what we spoke about, these 3 major conferences that happened within the last 6 months, something to just highlight is a lot of these clinical trials were actually open in Canada, so with real Canadian participants. So perhaps maybe a little bit of a highlight of which trials were open in Canada. And just to build on that question is, how do patients get onto a clinical trial?
So both Matterhorn and 577 were both open up in Canada. So the question about how do patients get onto clinical trials? So number one, I'd say large phase 3 trials are often, Canada is often approached, and so major centers will open them up. Unfortunately, Canada is also a very large country where access to trials is not always the easiest. So some of these trials are only in major centers. Sharlene's is our lead, is our chair for the GI tumor for CCTG or the Canadian Clinical Trials Group. And that's one of the missions is how do we make trials more accessible, especially for long distance patients. Like in BC, you have a patient in Fort St. John that's like 10-hour flight, or not 10-hour flight, but 3-hour flight from Vancouver. How do we help accommodate these patients? The other thing is not every clinical trial is also open across the country. And that might be just due to maybe it's a biomarker trial. And there's also financial considerations for centers to be opening up clinical trials. So in some places like Toronto may have a trial open, but nowhere else in the country. So there will be variability. Unfortunately, not every trial can be open everywhere in the country just due to if it's a biomarker or tests and things like that. So the best thing is a patient can always ask, are there trials that are available for me? Sometimes there isn't. Sometimes there's criteria that based on the tumor or the location or biomarker, they're not eligible. And I would also say, keep in mind, some of these medications are experimental, so they may or may not help as well. But I'll pass it on also to Dr. Gill, because she's the head honcho who helps us with.
I think from the patient voice perspective, just asking, just don't, if it hasn't been brought up with you as an option, just saying, is there a clinical trial available, or would I be eligible for a clinical trial? I have to say, I've been an oncologist like year 22. I think that message is getting out to patient groups, because in the last decade, increasingly the number of patients who will volunteer that will say, I'm interested in a clinical trial, in my clinical experience has really increased, which is great to hear, great to see that interest in patients advocating for trials. But it is true that not all trials can be done at all centers, and that a big part of that is around the safety and the governance and the safeguards that are in place, because trials are experimental and because trials have risks, to really make sure that they can be accommodated in a setting where those risks can be mitigated as much as possible for those patients who are participating in the trials. But just to ask if you put it out there that you're interested in a trial.
And don't be scared to ask, right? That's something we do advocate for our patients. I think a lot of patients think, oh my gosh, my medical oncologist or my surgical oncologist will get so offended if I ask. But I don't think that that's true, or at least
not at all.
Yeah, good.
Not at all. Yeah. In fact, I'm grateful to patients who bring it up, because you're saying that you're willing to be a part of a trial that may improve outcomes, not, for the community. Like there's a very altruistic element to being part of a clinical trial, as well as hopefully the opportunity to be, in a treatment that could offer, something better than current standard of care.
Actually, Katy, you bring up another good point. I'm on another patient group where about opinions about how to be in a trial and what are the barriers. And one of the themes that just came out of that was people are worried about pissing off their care team. And so first of all, I'm sorry if any patient has gone through that experience where they think they can't approach their care team with a question, especially for trials. We are very open to that. And the last thing we would want is for patients to feel that worrying us or pissing us off is going to compromise their care. And it's scary that sentiment is so prevalent. So I really want to put it out.
Yeah.
That should not be the issue. And if that's happened, I'm really sorry on behalf of our profession. So
Thank you. There's one last question, and then we'll just do closing. So this question is there any evidence of high exposure to radar radiation over a number of years to cause cancer? I guess specifically stomach cancer.
So I think I'm assuming by radar radiation, we're talking about radio waves, or which is usually what that refers to. So I think there have been some reports or concerns about things like cell phones, that kind of radio wave exposure potentially increasing the risk of cancer. To my knowledge, there is no convincing evidence that radio waves increase our risk of cancer. And no, I'm not aware of any evidence specifically to stomach cancers that's a risk. But I recognize that there has been research looking into that, because it is a valid question that has come up. So generally radar radiation refers to non-ionizing radiation. So that's usually not an issue, but if I misunderstood the question, then I apologize, but.
Oh, so there's a follow-up here from someone saying, what about if, I guess this is for military, what about if you're stationed on a ship? Or I guess,
Yeah.
that was a follow-up.
yeah, I don't think from
Yeah.
an occupational, there are certainly definitely cancers.
Because we do, yeah,
occupations.
and environmental issues,
Yeah.
right?
So we know mesothelioma if you've been exposed to asbestos, or firefighters have a very high risk of colon cancer. So there are certain cancers that are linked to occupations. I don't know if stomach cancer linked to anything occupational per se.
I think it is technically linked to firefighting. Yeah. It is one of for WorkSafe BC. So I was in the Navy, felt like the radars and paints and chemicals. I mean, I think the reality is that it's a hard that just following. I'm reading the follow up to the explanatory component of the question. I think it's really hard to know. I think we know, Teresa, to your point, that there are lots of potential environmental exposures that over time, like most of the association between cancer risk and environmental exposures is kind of related to cumulative exposure over time. So while you can say, well, generally this isn't a risk, I suppose if you have very consistent long-term exposure to the same potential toxin, is there a chance that could increase risk of cancer? There probably is, but it's a hard thing to prove. But I think the question refers to if it's not just sort of a one-time thing, but if you're kind of living in that environment for a long period of time. And but I'm not an epidemiology, I mean, it's something that would require some more specific research.
Thank you. So we're little bit over time, not much. So I just wanted, first of all, to say thank you to Dr. Sharlene Gill, Dr. Howard Lynn, and Dr. Natalie Coburn for taking time out of their busy schedules and to come and give us highlights from these very important conferences that happen that are very crucial for knowledge for the stomach cancer community. As well, I wanted to thank our sponsors. So thank you to Taiho Pharma Canada Inc. and AstraZeneca for their sponsorship so that we could put this webinar forward. Also, thank you to my partner Katy and to Stephanie, our events manager, for coordinating all of this. And most of all, thank you to all of those of you that have tuned in and stayed tuned in. Hopefully this was, we found this informative and educational. I know I did. And as I said, we will most likely have it up on our YouTube channel within the next couple of days. We'll highlight it on our social platforms. And if you have any follow-up questions, just you can send them to info@mygutfeeling.ca or even to events, and we can we will try to get them answered for you. For all of us, thank you all. Have a great rest of the evening and a great rest of your summer. And we'll probably be having another webinar in the early fall before our conference. So we'll keep you updated on that. But thank you everyone for participating and for your questions, and hopefully they were all answered. So good night, everyone.
Thank you so much. Have a good night, everyone.
Thank you.